So I'm Laura Esserman, and I'm a professor of surgery and radiology at the University of California, San Francisco, and I'm the director of our comprehensive breast program. And I come at this from the other direction, from the clinical side. And I first want to say that I'm incredibly grateful, as are all my colleagues, to the discretionary funds that you make possible and give to us, and that means that teams of physicians and scientists can apply the critical resources at a critical juncture when the opportunity arises. That allows us to be creative, chase new ideas, and do it quickly. And I think, like many of us, we've started many collaborations in this with the other scientists in the room, and it makes all the difference. Critical resources at the critical juncture to really enable us to be creative and work as a team with our scientific colleagues. That's really what's going to fund change and a cure in our lifetime. So I focus on one of the things that I have focused on is really, from my clinical perspective, is certainly understanding that all cancers are not the same. And that means that we certainly shouldn't be treating them all the same, and trying to figure out how we're going to separate them out. And that means also for different screening strategies, treatment strategies, and hopefully prevention strategies, because that's really what will make a difference. And if we really understand the biology of the tumors, the different tumors that develop, and really understand their clinical story, there's a lot of clues there. And my connection with this whole idea of angiogenesis is to also look at, the formation of blood vessels is created by, there are other bad cells in the neighborhood. And the other bad cells in the neighborhood that we kind of went after, and some of these clues came from our imaging studies with MRI, is the macrophage. The macrophage is a cell that's involved in inflammation. And as usual in the body, there are good kinds and bad kinds, and the switches that turn one cell from being good to bad is complicated, but I think we're beginning to understand it. And one of the things that I think is particularly interesting is that when you have cells in these, so particularly we looked at large cancers that grow quickly, and a lot of times people say that big cancers come from, are diagnosed because of neglect. But I don't think that's true. I think that there are some big cancers that grow very quickly. And those are the cancers for whom our screening strategies currently don't work very well. So we have to really come up with a different way of understanding it. And if these cells are a marker of bad outcome, there's some important things that we can do with that. Not only can we target interventions or target treatments to, as Judah says, attack the whole problem from a number of angles. It's like the tuberculosis story. But we can also start to look for these markers in the blood. Again, if we are going to really succeed, being able to have a surrogate or some kind of marker that you can treat without waiting for the cancer to develop is going to be the key to get us more towards prevention. And I think that, so having a marker that you can, that is a marker of bad outcome, it's part of the story. It's sort of a linchpin and what creates a bad environment and allows tumors to really grow. You could treat it, measure it potentially with imaging, you can find it potentially in the blood, and then you can start to be thinking not only about targeted drugs, but targeted preventive agents. And I think that's really critical for us as we move forward.